Live on time.
Yeah, okay.
So hi everyone, I'm Sarah Gordon. I work for healthcare science company ZOE, and we worked with King's College London to build the COVID symptom tracking app, which we created last weekend. In a weekend, got it live on Tuesday, and we're now at the stage where we've got nearly 2 million people in the UK tracking, and we're launching in the United States today. So here with me today, I'm joined by Claire Steeves, who is a clinical senior lecturer at King's College London, and she's also a geriatrician at Guy's and St Thomas's NHS Foundation Trust, as well as Tim Spector, who is a professor of genetic epidemiology at King's College London, and was the person who spearheaded this project for us to launch the COVID symptom tracker app. I'll hand over to you guys just to introduce yourselves, because I surely have missed out on some really exciting background on your experience in relation to COVID.
Go for it, Tim.
Okay. Hi, everyone. I'm Tim Spector, professor of genetic epidemiology, and for the last 25 years I've been studying these 15,000 twins. And really that I've studied anything that I think is of major importance for our health, of which obviously COVID is the big thing at the moment. We initially wanted to study the twins as the way to do this, and then we opened it up to the general population. I'll hand over to Claire to give herself a quick intro.
Yeah, so I'm a geriatrician and also a researcher in Tim's team. And I've been studying over the last 10 or so years why individuals might be varied in their aging responses. And some people are very vulnerable to health problems as they get old, and some people are not. And of course, that's definitely true of COVID-19. So Tim, I think it was like something like Thursday morning, was it, when suddenly we were sort of saying we need to get a symptom app out to the twins, and you said, can you put something together? And I was very keen to do that because I'm already seeing patients in my clinical role, and I'm also, many staff members have symptoms of COVID, so I've kind of got an anecdotal understanding of what people are presenting with. But we wanted to put this into some kind of bigger data collection across the country. So therefore we sort of wrote down as many things as we could put together and talk to ZOE about how to make this work in the real world.
And amazingly, they agreed to do what was really a 4-month project in about 3 days. And that's why we've been ahead of the game across the world in coming out with this app that is actually able to capture these new symptoms as they're arriving in real time, rather than waiting for a few weeks or months until the crisis is past or it's a little bit too late. So it was a really exciting partnership between the academics and and ZOE, who are a spin-off from King's College London, working together. Small groups can get things done really super fast, and it's a source of great pride to us all that we managed to get this far so quickly.
Yeah, definitely. And just from the ZOE team point of view, we've gotten thousands of bits of feedback about the app in terms of technical updates that we're making, suggestions for symptoms. Claire and Tim are going to talk about some of the symptoms that we have added based on things that they're seeing in clinics and in hospitals, as well as some symptoms that we actually think more people have versus fever, which Tim and Claire will talk about shortly. We've got some exciting maps and graphics to show you some of the data that we're seeing that the scientists are analyzing at the moment. But just so you guys are aware, we have got push notifications that should be live on the app soon to remind you to log every day. Will allow you to reset your passwords, which was in the early stages of the app. We've reframed some language around gender identification, which is really important to us to make this accessible and inclusive. And there are many, many more updates coming out in the app, in addition to the US app going live today in the United States, in collaboration with Massachusetts General Hospital and scientists at Harvard and Stand Up to Cancer. So we'll have more of an update on that on the website. So it's covid.joinzoe.com, where we'll have daily updates, and we'll be posting a link to a weekly webinar every single week in the coming months. So Tim and Claire, what is some of the early symptoms that you guys are seeing based on the data in the app?
Well, we were very interested to add in three symptoms really in the middle of last week, which we know from sort of anecdotal cases are really key. The first is loss of taste and smell. And the second was chest pain, which, you know, quite a few people are reporting. And the third is a hoarse voice. And we've done some quite good stuff, I think, now, Tim, which maybe you could talk to, around sense of smell. It appears we've got now quite a lot of individuals in the symptom trackers who have actually been tested, and of them, a good number now, you know, nearly 2,000 are positive, have said they've had a positive test. So using that smaller data set, we can see that loss of sense of smell and taste seems to be a really important symptom.
Yeah. So when you look at this, obviously, you know, there are obviously limitations of basing the diagnosis on self-reports, but we hope we can get around that really by the sheer scale of what we're doing and the hundreds of thousands of people that are applying in each category to see if they make sense from a pathological or clinical point of view, rather than just sporadic areas where there might be a bit of anxiety or a bit of seasonal allergy or any other kind of thing going on. But we are seeing these clear patterns. Fatigue is by far the strongest common denominator here, and there are about 10% of people who really are so fatigued they just can't get out of bed. It's like me on Monday mornings. And the other one is these fevers that the standard definition is actually quite common on the NHS website, the fever or persistent cough. But most of that is made up by persistent cough rather than fever. And it turns out that actually fever across the country, according to our latest data, is only around, is less than 5% of the population. And so it's actually rarer than that. So I don't know if you've lost the screen at the moment or not, you can see it. But the other ones that Claire was mentioning are these chest pain, which wasn't on the classical list as important. Hoarse voice, again, quite a common recent observation by clinicians that this is the case, and may have no other symptoms at all, just, you know, losing a bit of smell and your voice is hoarse. We think this is a pretty good indicator of what's going on because they're quite specific. Things like fatigue is not very specific, nor is often shortness of breath, but these others are more. And in the elderly, you're getting confusion. This is commonly seen in care homes, as Claire knows, and even abdominal pain. So we're putting these things together so that we can actually get algorithms to work out which are the key ones. But for the moment, we think the most exciting stuff going on is tracking the lack of smell and taste, which seems very specific to this virus, and is very strongly related to being seropositive. So it may be a better indicator than fever of actually having COVID, which is intriguing and could have big health implications as well.
Claire, I'm not sure if you're able to share the graph that you showed me before this call on the clusters of symptoms. Are you able to share that?
Yeah, with symptom positive, I probably could. Yeah, let me see if I can try.
So this is the overlap, just while Claire's doing that, to show the overlap of how these symptoms cross each other. So generally you get more than one of these symptoms together. They're not usually isolated, and this demonstrates it quite nicely. So Claire, carry on.
So this is a sort of Venn diagram, as it were, of people who've tested positive for COVID versus people who have. So it's that group of people. It's not people who are self-reporting symptoms overall. And so it's quite interesting to see how these symptoms overlap. And it looks like that if you're mapping cough, fever, fatigue, and anosmia, you probably are capturing most people that are symptom positive. There are, of course, some people who have cough that don't have, quite a lot of people who have cough who don't have, are not COVID positive. So if I show you the graph of the negative ones, that's quite interesting to look at in contrast. I'll try and do that
Just say
now.
what is anosmia is just the Greek word for lack of taste or smell.
Thank you. And we just had another question from Michael, who said, are you looking at which symptoms tend to go together, which is what we're discussing now, and the relative timing? And I think on the relative timing, we need more data over a longer period of time to understand, what symptoms occur as and when. Tim, I'm happy for you to chat more about that.
Yes, so at the moment we're just getting a snapshot. We haven't analysed our longitudinal data yet, because what we want to see is which of these early symptoms are predictive of people who end up in hospital, for example, or which are predictive of people who have very mild outcomes and really, can get back to normal activities very, very quickly. And our data isn't dense enough at the moment to tell us those things, but it is certainly telling us and allowing us to tell clinicians that they should be really alerted to these particular features of the condition and not ignore it as something unrelated, because clearly they are clustering together in ways that would suggest they're real rather than just random events.
Tim?
Yeah, so here I've just shared another Venn diagram, which is the way that symptoms cluster in individuals that have had a test for COVID. So they must have had some reason to go and see someone and have a test, but they've actually tested negative. And so here you can see that there's a lot of fatigue and cough, which might be not specific to COVID, but whereas the anosmia, fever, and cough and fatigue together is the cluster we think is probably going to be quite helpful.
Yeah, although I have to remember that the gold standard of the test is not actually that gold standard, because although if it's positive, you're pretty much sure to have the disease. If it's negative, it's not always the case, and you may have to do multiple testing to be sure. So that we call that the sensitivity of the test is not 100% at all, even in the best tests. And that's just because you have to pick up the virus at exactly that right time, and it may be that your body's not producing it then, and it might do at a later time. So we might be underestimating that. So some of those groups may be real, and they're just being labeled as not having the condition. So it's not an easy condition to diagnose in any way, really, whether clinically or even with these tests. They all have their faults.
So one of the questions we have from Paul is, what proportion of people have COVID type symptoms? And I think, people want to understand, how are we able to indicate if someone has COVID type symptoms? Do you want to talk a bit about that?
Yeah, I mean, our estimates so far are based only on the respondents. And so it's possible that the early ones are not totally representative because they're slightly younger than the others and maybe keener to use an app than other people or report things. But we're getting somewhere between 25 and 30% of people reporting some symptoms that have been linked to COVID in the population. And that seems to vary by area quite a lot. When we start to look at the maps, you'll see that most of the high density of symptoms is occurring where most people live, in the big cities.
Shall we move on to the maps?
Yeah, I think it's a good time to do that, because the whole point of this was really, the concept was to deliver a form of early radar detection of things happening that would alert the NHS 2 or 3 weeks down the line that someone was likely to need intensive medicine or intensive care beds, rather than waiting just for confirmed cases in hospital or deaths. And so this is the rationale behind this. So this is a map of the UK, and the darker the green color, you can see the greater the percentage of cases who are complaining, in this case, of loss of smell or taste. And you can see there's a few hotspots there, but most of them are around the big cities. Not all of them, but most of them are around the big urban conurbations. But some of the areas where there are not many of these sites also reflect the fact we may be not getting the coverage yet in all the parts of the UK. Even when we've got 2 million people, if they're clustering around cities, we're not getting enough of the rural ones. And as Claire was saying, we're not getting enough of the over 70s, where we really do need to get more people logging, or get younger people to help them log. So that's what we think may end up being one of the new definitions of this disease, loss of smell, those patterns, and we'll be tracking those over the coming days and weeks to see how that map changes. And if we go to the next one, we look at fever, which is the traditional way to look at flu and other viruses. Generally, it causes fever, and most people know when they've got a proper fever. It's they can usually separate it from a cold, but there will be some overlap. But again, the distribution looks fairly similar to what we saw on the lack of smell and taste. And then if we go to the next one, which is on a smaller subset of around 1,000 people out of, I think it's nearly 3,000 now, Claire, looking at the latest data that we've had testing on, as people are reporting in daily. We see that actually this probably reflects where the testing's happening, which is generally in the south of the country, more than anything, because some areas really, I don't think, have full access to testing. Maybe wrong, but that's what I think is happening, to slightly distort this map. So, but we do see some hotspots down there of testing. Southampton and
really well.
Portsmouth. Those areas do seem to be quite big, where there is a regional testing centre as well, I think. Yeah. And finally, the map below that is the one where this is persistent cough. So again, this is the NHS definition of COVID, is someone having quite a severe persistent cough. And you can see, again, some slight differences. For example, just notice that Cornwall seem to be coughing more than they're getting fever. And a few other areas there are coughs around. And I think it might be harder to separate out the coughs that are COVID-related coughs from other reasons for coughing, such as seasonal asthma and things. But again, these are things that once we have a greater look at the data, we can start to put this into artificial intelligence. We can start to parse these things apart. Claire.
There are quite a few questions in the Q&A about benchmarking this versus baseline flu and cold symptom data. Does that data exist?
So baseline symptom data.
Yes.
So yeah, so remember that over 70% of people logged in the first time to say they were asymptomatic. So we hope that working with another group here at King's, from the Imaging Sciences group, big data group, we should be tracking these things over time. And particularly interesting, the people who reported to be normal one day and then 2 to 3 days later, they come back and say they've got symptoms. This is going to be super helpful to working out the speed at which things are happening in the country. So that
I just note that Paul Franks put a comment up about Yorkshire there, and it's worth noting that, and somebody else sort of said about the maps being quite useful as a recruiting method. One of the things we've seen is we've looked at the proportion of people that are on the COVID tracker compared to the proportion within that area, and looked at what percentage basically coverage per area that we have with the COVID symptom tracker, and it's about between 1% and 6%. There are very few areas that are below 1%, but one of the areas is actually the northeast of England, where we seem to not be getting as many people on the tracker. So we do need to really push in these areas where we don't have very good coverage.
We have quite a lot of questions about whether or not we're planning to publish the open data set. So we'll be publishing maps and things like this on covid.joinzoe.com on a daily basis. And then another, quite a few questions about how we're sharing this data with the NHS, with the government, with local governments. Do you guys want to give a quick update on that? Because there's lots of exciting things going on.
Yes, we've just agreed today. We've been in discussions for the last 3 or 4 days with the Health Data Research UK Centre, who have we're sending our data to. They've got a secure pipeline built for us now with secure servers that have the highest levels of security in them to retain this data, and that's going from ZOE's app through them on a daily basis, and so those will be updated daily in their database, and that's being distributed to the 4 NHS regions and to other key researchers that are after this data. So our aim is to get this data out there as rapidly as possible, and while people are getting set up, we at King's and our partners are analysing as much as we think the most urgent data there is to get out there that's going to actually influence policy in the next few weeks. But we hope that as more people get hold of this data, we'll be able to get many more insights. But it all depends really on keeping the momentum going, spreading the word about the importance of getting maybe up to 5 million people, I think would be better than where we are at 2 million, get a better spread around the country, fill in those gaps, fill in the gaps in the elderly, and make sure that everyone realises how important it is to keep logging on every day.
I've got a question.
Yeah, so that we can create a map, of symptoms over time. Go on, Sarah, sorry.
A question from Caroline, who's asking, could different strains be occurring in different parts of the country? For example, why coughs are seen more frequently in Cornwall versus other parts of the country? And it might be interesting to talk about viral load.
Yeah, they're different questions. So we'll handle, so certainly neither Claire nor I are virologists. We should mention that, but everyone is having to be a virologist in this time place because there aren't enough of them. And certainly a number of studies are coming out showing that the different virus strains, where you have one species but still multiple strains, multiple little subtypes that might behave slightly differently in different populations. And that's how they can trace which of these viruses have come from the Netherlands or China, or which particular outbreak, or Italy, whichever it was. So they are different, and it is quite possible they behave, either the strain behaves differently, so that hypothesis that it's causing cough in Cornwall, but it's causing loss of taste in Yorkshire, is because of slightly different strains. That's all perfectly possible, but until we get actually more detailed testing and actual sequence data, which is much slower to get than just working out whether you're infected or not, we won't know for sure. But we're keeping an open mind because we know so little about this virus and what it can do. And it may be that the same strain in different genetic populations also has a different effect. So the fact that it behaved maybe differently in Asia to European populations may be due to our genetic makeup, or it may be also due to our immune systems, which do differ, or even an area close to my heart are gut microbiomes, because that is the thing that is most different about all of us. We share 99% of our genes, but only about 30% of our gut microbes, which are crucial for our immune system. So these are all fantastic questions.
And the question on viral load, that's interesting. And I think it's relevant when it comes to anosmia, that probably people who have mild symptoms are probably shedding less of the virus than people who have very florid symptoms. And I guess that's probably behind the NHS advice to stay isolated if you have a cough or a fever, because those people are probably shedding a lot. But I guess our interest in the milder symptoms is because those people are people who have just as not anosmia, a bit of a hoarse voice, might still be going out and going to the shops and so on. And even though they may have a less viral load, if they're going about around the place much more, they potentially are important spreaders at the moment. So that's why we're really focusing on that question right now, because we think that that actually could have a significant impact on our nation's health if we can, if it's true that anosmia is related to COVID, that we get that message out there quickly so that health advice can change for that group.
We've got a few questions around supplements and medications. So we've got 2 questions around supplements and 1 on medications. Are we asking people to track supplements and medications?
We're not asking about supplements at all. Sorry, Tim. We're not asking about supplements at all at the moment. Obviously, there's always this balance between asking too many questions and getting the really right questions in. But we are asking questions about medications which other people, other scientists and other nations have shown to be potentially important in COVID infection. And so we will be, we are feeding up any findings that we have, and we'll be publishing them when we're sure of what we're finding.
Perfect.
Medications are important, and we are, for example, asking about non-steroidals, which a lot of people are interested in, corticosteroids. So, we're still analysing the data, but certainly for those 2, we're not seeing anything particularly worrying at the moment, but we need to do more detailed analysis.
Absolutely. So for healthy people, there's a few questions around, if I'm healthy, I have no symptoms, do you still want me to log? Why is that important, Tim?
It's vital to know which areas of the country really don't have much of the virus. So we can paint those areas as the moment it looks like, Cornwall and Norwich, for example, Norfolk, and most of the north of Scotland seems to be pretty, but we're not sure yet that's because people there are not logging, or because there's few people there. So we really do need people in all parts of the country to do that. So that gives us a snapshot, but also if they do get the virus, and we think there's a lot of mild disease going around, that it could end up with very large percentage of the population getting it, we can see the speed at which that's spreading, and really the epidemiology modelers will be able to see in real time how these infections are spreading if they've got the baseline knowing who's recording it. So if everyone can do their bit, be a citizen scientist for us, we can learn masses.
Absolutely. There are a couple of questions around immunity. Now, Tim, you talked about gut health a bit earlier, and there was some scientific research published about a month ago about the New Age diet helping fight frailty and things like that. What things that you're seeing on social media are facts and what is fiction around improving immunity in this time?
Well, there's obviously at these times you get the full diversity of human nature. Everyone's anxious and often reaches for things that are a quick fix, and so there's been a run on all supplements and vitamins, particularly so-called immune boosting vitamin supplements, and the evidence for any of them, when you look at the literature, is pretty dreadful. And I would say there's absolutely none for anything except possibly 2 of them. One would be zinc, and that data is about 20 or 30 years old and really hasn't been updated, so could be flawed. I haven't seen any good recent publications on zinc, and every food manufacturer just adds a bit of zinc to their food, tiny amount, and that gives them a tick to say it's immune boosting. And there was one report in vitamin D of a summary of a few bad studies to show it could help the immune system. But most vitamin D studies for all conditions have been proven to be not helpful. So I'm rather dubious that any supplement is very good. And what's more important is a balanced diet, diversity, people still managing to get plenty of diversity of plants, fruits and vegetables. That seems to be the way. If you can keep your gut microbes healthy, that's the most certain way you can maximize your immune system. And hopefully, we don't have any proof of this, but we think likely to minimize your risks or potentially help your body respond to the virus positively.
Alison is asking, what about vitamin C, Tim?
Vitamin B.
Vitamin C.
Vitamin C. All the meta-analyses of all the trials have shown that vitamin C doesn't prevent any infections. There's some evidence that if you take large amounts, just as you get a common cold, you can reduce the symptoms by about half a day. But you have to time it perfectly. So again, much better to have fruits that contain vitamin C and vegetables that contain vitamin C rather than depending on stocking up masses of this chemical. And a lot of these vitamins in large doses can be very bad for you. There's probably more people dying because of taking vitamin supplements than are ever saved from them, because the body isn't used to taking that amount of these chemicals. They're used to small, steady amounts in food rather than this artificial ones. But Claire might have some different advice for the elderly.
Well, no, I was just going to bring up the thing about fresh fruit and vegetables. In the time of this sort of crisis where we're not able to go to the shops frequently and the shops are sort of sold out of stuff, it's important to make sure that everybody in our society is benefiting from fresh stuff. Because would you not say, Tim, that potentially fresh fruit and vegetables might have,
Yes.
certainly more vitamin C?
There are actually a lot of surprises out there, that some things that people think as non-healthy are actually quite good. So frozen peas and carrots, for example, have good levels of nutrition in them and polyphenols, and things like canned beans, legumes, chickpeas are pretty much as good as in their natural state. And
that's good to hear.
People worry, frozen berries particularly also do keep all their nutrients in them. So there's no, just because something is cheap doesn't always mean it's bad. So a lot of the fruits and vegetables, if they're preserved and cooked correctly at the beginning, are still excellent sources. So we shouldn't be too obsessed with getting absolutely everything fresh, 365 days a year. If we pick our foods correctly, they can be cheap and nutritious. And tomatoes are another, canned tomatoes probably as good as fresh tomatoes, which aren't fresh anyway because most of them are imported from Spain or the Netherlands.
Can I say a bit about exercise, Sarah, before we go on?
Yes, please. And just on that note about food, there's a few people who've mentioned, I'm self-isolating. I'm not able to get supermarket delivery. There's no fresh fruit available to me. I think the advice that we'd give is to find somebody in your community. I've seen so many community groups spring up in the midst of this pandemic. So please find a local Facebook group or someone on your street who can help you do your shop.
WhatsApp groups very big in our neighborhood, and I think there's always somebody. It's just a question of getting in touch. There's plenty of people around to help, but again, don't worry about plenty of these canned products and these frozen products are fine, so people shouldn't worry too much. For a few weeks everyone will be fine, and I think there's the danger of overreacting and getting too stressed out. Humans are built pretty tough. Evolution has given us lots of periods to test our systems against this. But having a network of friends is definitely, or even new friends, is definitely the way forward.
And exercise, because obviously exercise has a major effect on the immune system. And I mean, people have shown, some of our collaborators have shown that exercise, even within quite a short period of time, can really improve your neutrophil function and the rest of your immune system. So, you know, how do we do that in the time of isolation and so on? Well, it's nice to know that we can still go out running in the park, but there's loads of groups, aren't there, online now doing exercises for all different types of people, from sedentary, very frail, to sort of kids and so on. But I think so half an hour of exercise a day is a really good thing to be doing at the minute.
Absolutely. A few questions on meat. Is meat okay to have at this time? Do we plan on having people track their diet in the app? I think at this stage that's not in the plan, but perhaps you could say a bit about meat.
Yes, so humans don't need that much meat to avoid, the only reason to have meat is to avoid vitamin B12 deficiency, and in some people possibly iron deficiency. But most people, like myself, are fine on eating meat once or twice a month. And perhaps this is a good time for us to eat generally less meat, where there's a pressure on it. And around where I am, there's large queues to the butchers, whereas the fruit and veg shops, it's much easier to get your stuff. So don't worry about getting regular meat. It's not going to protect you against the virus or help you in any other way, but it is. But if you can get it, always try and get higher quality meat, less of it, but higher quality, rather than eating bad quality processed meats, which will probably be bad for your gut microbes and therefore your immune system. So I think the idea is to think there isn't one food that's going to save you. There's not one superfood. It's about getting that right balance. It's getting that healthy diversity in your gut, making sure you've got as many diverse microbes producing immune friendly chemicals. That's really the key here. And so don't get obsessed about meat. That's the key there. We're not going to be able to track nutrition. That's actually, although that's the reason this app was developed, was because Claire and I have been working with ZOE, this company that we developed a nutrition app to look at personalized medicine, and that's fortuitous. They were around and dropped all that in order to help us do this fighting the virus. But any other questions on food?
No, I don't see any. We've got some questions around, well, one on electrolytes. So Ian says that his son was having electrolytes and that has seemed to help, as in addition to some medicine for people with pneumonia, which seems to have helped.
Yeah,
I don't know.
I can't answer specifically on pneumonia. I mean,
No.
unless in hospital, I wouldn't have thought people need special products. The key is to hydrate, and water is pretty much the safest thing to hydrate with, unless you're having massive digestive problems. There's no evidence generally that any of these electrolyte drinks are good for health. They're mainly marketing gimmicks, in my opinion.
So the person might be talking about antibiotics that are sometimes needed in COVID infection. For the secondary infections that come after the virus is there, there's often a bacterial infection that follows. So it's not unsurprising if you are admitted to hospital with COVID that you might be given antibiotics if people think that there's a secondary bacterial infection as well.
But it doesn't, just to be clear, antibiotics do not help against the virus, and if taken too early, they can make it potentially weaken your system and your microbes. So don't rush out and take antibiotics on your own. Is also the message.
Cool. A couple more questions on whether or not we're tracking medications and their impact. We answered that a few minutes ago, and the answer is no at this time. We've got a few questions around ACE inhibitors. And I know that you guys are starting to look at that, but I don't know if we're ready to comment on it because we don't want to give advice on some items yet until we've formed an opinion from a scientific perspective.
Yeah, just to say we are collecting data on this. So everything that's topical we can collect. And so I think we have logged over 25,000 ACE inhibitor users. And so we're looking at that data carefully, and there are reports out there of it being either good or bad. We don't know at the moment, but we hope within the next few weeks to be able to give more definitive answers.
Great. Cool. I think we're going to wrap up. Thank you so much, Tim and Claire, for your time. I'm conscious that you guys are working to treat people, so we don't want to take up too much of your time today, so that we can let you get back to doing that. It's hugely important. We've had quite a few people ask about updates to the app. We are making updates to the app and will release push notifications imminently. Quite a number of you have suggested that we allow you to track for multiple members of your family, including older people. This is something that we are definitely working on, and will announce on our blog as soon as that's released. So please have a look at covid.joinzoe.com for updates, where we'll be publishing things daily, including the maps that you saw on this call. If you've got any feedback, Zoom will send you an email after this, so please send us your feedback on this webinar. Like I said at the start, we'll be doing a webinar every week with different scientists who we're working with. Next week, we're hoping to have Andy Chan from Mass General Hospital, in addition to some of our American scientific partners on a call as well. So I will make sure to go through all of the questions that have been on the chat and on the Q&A that we didn't get to cover this time round, and we'll do our best to publish things as soon as possible. So thank you so much, Tim and Claire, for your time. Thank you, everybody, for joining our webinar today. And please visit COVID, that's COVID.joinzoe.com, and we'll have more updates there. Thank you.
Bye, everybody. Thank you for listening.